Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric O'Kelly. This week, we're with Francois Duquette, who is a nurse from Quebec, Canada. Francois, welcome to the program.
Thank you, Aebhric, to welcome me. I'm happy to be here with you.
So, tell us a bit about yourself and what's keeping you busy.
So I have an academic background that's a bit different from what we typically find in the nursing field. I hold a bachelor degree in political science, a master in international relations, partially complete, a diploma in nursing, and I'm currently pursuing a master's degree in health law and policy. But since 2017, I work up north in the Great North in Quebec, so with native communities. I began my practice in a hospital before moving to work in northern and remote regions. First, I'm definitely an emergency care kind of guy. I've done some post-cardiac and low intensity intensive care units, but my true focus is emergency management of patients with cardiac issues and trauma. But after a few years working in ER, I complete what we call expanded role training program. It's a 145 to 170 hours course focused on clinical assessment. And because it's important to understand that in northern regions, I often work without a physician on site. So we operate in remote clinic. So we need to align our clinical assessment as a nurse with medical terminology to ensure that the physician, sometimes 200 kilometers away, can accurately visualize the patient we are describing. And working there, I quickly realized that healthcare professionals had limited access to training, education. So I pursue additional training in critical care as ACLS, neonat resuscitation program, Stop the Bleed, TNCC for nurse in trauma for nurses, medevac, triage, wildlife, advanced wildlife support, a POCUS, and I become instructor for several of these courses. And my goal was to train others and help foster nursing empowerment.
So you're doing expanded scope of practice for those working in very austere environments. What is that? So what advanced skills are you able to do that a normal nurse working in southern Canada isn't?
By the regulation and by the law, I have nothing that I cannot do in the south of Quebec, but it's more the practice. We are often in a situation that because we don't have any physician with us, we need to adapt our practice and go at the very end of the scope. That's what I'm allowed to do. We work under collective prescription, so the low intensity and low mortality problematic, I can deal with that, like STI, low intensity trauma, UTI, STI, ears problems, skin problems, things like that. But that a moment become a bit more and that I'm not sure what I'm doing, obviously, I would transfer the patient in medevac to a regional hospital. But the problem is in these hospitals, they doesn't have OR, no scan, only very small radiology and laboratory department. So often they also have to transfer by medevac the patient south in a big and specialized hospital.
That's quite interesting. So you're doing a lot of general practice, kind of community care aspects, but then if there's a massive trauma or something major, you'll stabilize and then put them out on a fixed wing medevac?
Correct. It's like, and also we have like public health that we help because we still have a lot of tuberculosis up north and a lot of STI and also COVID. It hard up north. So we have nurses who become specialized with this kind of problematic without any like medical background or or physician close to us. And the thing is also in some clinics we are only two nurses. So imagine at the moment we have a small trauma, we're done. We become an orange code because if I have four or five patients and we are only two nurses, but I only have two hands and one stethoscope, so I cannot take care of a lot of patients at the same time. So the start triage is very important for us when we have some trauma.
So, do you have EMRs or primary care paramedics to help you up there?
Not at all. We have first responder who often is member of communities. So they have a small training, I think, but not sure. It's around a week, and after they come to help us. We also worked with police officer up north. Before it was the QRPG, the Quebec Regional Police Force. Right now it's Nunavik Police Force. Um, some of them are very well trained. Others become some police officer, work there first, and after they apply on Vegas police force. So sometimes it's more like a transition post. So they don't take care or take the time to be trained in trauma. But often we have very good collaboration with them, and they help us a lot because in resuscitation, like pump, everyone can do CPR. So it don't need to be a nurses or healthcare professional.
So, what is your use of POCUS, the point of care ultrasound, for assessing these casualties?
Yeah, unfortunately, the POCUS is not deployed up north. Um, some issue with the financing of this instrument. Some doctor use it. Some physician is well trained with the POCUS, and also the ADU. A lot of them follow the AGLS, the echography life support, but not all of them. But for nurses, it's a bit more complicated. We don't have really access, and also uh, I'm not allowed to not to tell what I see on the to the POCUS, but to like analyze and give result to the doctor because it is water, it is blood. It's the scope of practice with echography for nurse is a bit restricted up north and in Quebec in general.
So, you have the ultrasound there. You can take an ultrasound scan, and can you send that to the doc for review?
Yeah, that's the thing. In some clinic, they allow us to do that if we are trained. Um, some of us are. So in this situation, if you have good contact with the doctor and the doctor trusts you, you can use it, the echography. And also, sometime 3 times I use the echo machine with FaceTime on my phone,
Hmm.
so the doctor can see what I see on the machine, but I cannot interpret the result. And a lot of times I cannot do a lot of things after that because the doctor take care of, but they are far away. So they ask for medevac, and after the patient will be taken care of there.
Well, it sounds like you are using it. I mean, it's a fantastic option for ultrasound to be able to scan and then send it to someone who has more training to review.
Yes, but it's not all of us who are able to do it. A lot of nurses doesn't want to know, doesn't want to learn. Sorry, the POCUS because they are scared to miss something or. But it is what it is. We some of us try, and often we just show the other nurse how to use it, and they like it. But also, as I said first, the problem is very small community. Some community up north is only 180, 100, 200 patients. So we don't have a lot of use of this kind of machine. So for the government, that makes no sense to invest money there because, as I said, and unfortunately, that's one of the part of the discourse. Uh, we are nurses, we're not physician, so they doesn't want to invest things like that here.
So, can you tell us about one of the more intense experiences you've had whilst working up north?
Yeah, during the last 7 years, I had a few very good story, but one of them is when I worked in it's an Inuit community. I worked there with a physician, Dr. Steve Arnold. Steve Arnold is one of the best doctor I ever worked with him. is he do magic with nothing. And for real, I think it's going to be a good fit with you if you can have a discussion with him. But one day I was on call. I received a first call from a police officer for someone who tried to hang himself. So I arrived at the clinic, and fortunately, because the guy was drunk, doesn't use the correct rope, and the rope cut in two. So the guy fall on the floor. So I take care of this one, and I receive another call. It's a lady, 8 years old, with anaphylactic shock. Uh, she was swollen all the face. The airway start to be compromised. So I give her a first shot of EpiPen, and I set my things for other adrenaline shot. But she don't react very well to the shot, so I had to give another one, and the situation start to being worse and worse and worse. So after the fourth shot of EpiPen, we start to using the other H1 and H2 receptors. So I give her Benadryl, Zantac. I give her a lot of liquid, obviously IV liquid, and the situation just going down and going down and going down. So the doctor arrived, and we deal with the situation. We had to medevac her. We were able to keep the airway open, but very stressed situation. Imagine I'm alone with the doctor, so only four hands on the deck. The medevac arrived, patient left. I wait for the second medevac because for my first patient who have to be put in hospital in a psych unit. And during I wait the second plane, I receive a third call. It's a lady who feel a bit dizzy. She doesn't understand why, and since when, but a lot of blood in her bed. So when the patient arrived, and I don't have any laboratory here up north, so the doctor have to come back. We try to fix the things that doesn't work. Because we have to medevac her too. So after the medevac, we know that the hemoglobin was a 55, and we don't have blood up north in the clinic. And the hospital, they have some, but not at the clinic. So after 3 patients, I will hope my night was over, but that was not the case. A few hours after, we received a call that the lady stabbed her husband after he had an affair with someone else. So we have 2 patients. The male arrived with a knife still intercostal, so it's fixed in the right lungs. And we also had the lady, because the man fight back. So we have 2 different patients at the same time with trauma. So everything was gone. Will be done, and we transfer the man, but no more plane are available because the pilot maxed her hours of flying. So we have with the police, they decide to keep the lady in the village for a few hours or maybe a day until they can transfer on the big city and for facing the consequence of this act. And the day after, we have an elders who die in the community. And during the ceremony, the same lady come back to speak with another specialist, not a specialist, sorry, with a social worker. And she fell in dissociative shock after using some narcotic. So imagine that during the last day, I have no sleep, a lot of different patients with very low intensity during the day, but this night was a bit busy. And the day after, I have to deal with a patient on dissociative shock who start to convulsing after a few moments. And I was lucky, I was with another nurse there. So we take care of the patient until the doctor, the physician arrive, and we can like transfer again the patient. But up north, it's always transfer, transfer, transfer. That's one of my biggest night that I haven't ever had. And also, one day in another community, I had a chance to work with a very nice nurse, and unfortunately, she had a family emergency, so she had to leave the village. But it's a very quiet village, so my boss told me, "Look, Frank, the replacement, like the other nurse who's coming, will be there in 48 hours, but it's very quiet community, so everything will be fine." And the karma hit the fan.
Yeah, you say the
So
Q word. Anytime you say quiet
yeah,
in medicine, yeah.
yeah, and that's happened often in the ER. And up north was my first time someone tell me it's gonna be quiet, and yeah, the karma hit the fan, as I said. And so after the use again the word quiet, that's never a good thing, as you say. Um, the lady left the village, and I have patient who arrive at the clinic after an accident. It's car against ATV. Three patients, one be a red on a start triage, and two yellow. But was my first time ever that I told someone with open broken fracture to wait in waiting room, because I had other patient worse than him. And after that, I will say that my clinical assessment and the view I had up north completely changed, and I started doing a lot of training by my own for be able to deal with things of like like kind or situation like this one. Because when you're alone and you have three traumatic patient, yes, the police officer helped me, but he was alone too. So it was only him and me trying our best. Fortunately, no one passed away after the situation, but was a lot of stress happened there. And also, only one airport there at Kuujjuaq, the big airport with the paved landing place. So the jet for the government, the hospital, the hospital plane.
Yeah, fixed wing medevac. Yeah.
Yeah, the fixed plane, but with the government, so it's a jet. That's the only place they land. They land only in two different hospitals up north, Kuujjuaq and Puvirnituk. The other one, the alley are not paved. It's like small rock. So they never land a jet there, because if rock go in the motor, they're done. So we have to always do a double medevac. We have a small plane. Sometimes it's like I don't remember the name of the plane. So like Piper Navajo, who come land there. We transfer the patient in this plane. The first plane go to Kuujjuaq or Puvirnituk, and after the big jet comes. So it's always like a double step medevac if you want to go up down south.
Yeah, we call it wingtip to wingtip transfer. So the two planes kind of match up, and yeah, you go from the small plane to the big plane.
Unfortunately, that's not what happened up north. It's never transfer plane to plane. We receive the patient, go back to the main hospital up north, like Puvirnituk or Kuujjuaq. The doctor tried to stabilize the patient, and after the second jets come to pick up the patient. Because we only have two of this jet in Quebec. And if you look at the map, Quebec is very large, it's big, so it's not always available. Sometimes it's maintenance problem. So unfortunately, we can all never do wing-to-wing medevac. We always have to transfer the hospital first.
So you've had some quite interesting experiences. You had a day with 6 medevacs in once, and then you had in another situation you had someone that used the Q word, and you wound up having some difficulties.
Yes, but for be honest, it's not always like that. It's pretty rare. It's more we are busy during the day with few patients, sometimes between 12 and 20, but it's not always the big case. We always remember the big one, of course, but it's not the reality. I will say maybe 90 to 95% of the time, it's very regular patient that we're able to take care of. If not, we're going to transfer him, but it's not like a big dead or alive situation. But imagine working without any like radiography or any machine. One day I have a patient have pain on the left side of his belly, very like not swelling, but we feel something around on this on the left side. A lot of pain only on the left side. So we think about diverticulite. Say maybe that's a problem. We transfer him in Montreal, and after a scan, the patient had appendagite epiploide. I have no idea what is in English. The doctor explained me is like a small ball of fat all around the diverticulus that protect that, and sometimes you have some inflammation, and that's what the situation for the patient. But without scan, you cannot correct diagnostic this kind of problem.
No, even ultrasound. How would you know what that was if you looked at that with? I do a lot of ultrasound. I wouldn't know what a fat ball looked like.
Yeah, correct. So you need to transfer patient down south for no. After that, you discover that's not good reason, but you don't know when you saw the patient. So we have unfortunately a lot of false medevac also. We transfer for be sure, and nothing happened. And imagine, Aebhric, some clinic doesn't have EKG.
Wow, like they're handheld 100 euro ECG machines now. How can you not have a ECG?
I don't have any answer to that. Fortunately, he's not up north. He's more in the east. So we have some community also on the east side of Quebec. And when I worked there, because they have road to reach the community, the organization decided to not put AKG on this clinic.
So in my computer bag, I have a credit card size device that does up to 9 leads and SpO2. It's mental that you don't have access to that.
Yeah, and sometimes it's happened to me one or two times. I have Prince Metal um, angina for on the patient, but I don't have any AKG for be sure that's nothing else happened. So I called the paramedic because in this place we had one, and they have the MDSA, so they have the machine. So I can have like a 6 leads EKG and 9 leads EKG. So I have some image, but it's not enough, and you cannot do a 12 and left and right heart for be sure nothing happened. So, but at least I have some image. But in some clinic, we don't have any EKG.
That is austere. That is very austere.
Yeah, yeah, and it's like the instruct. Yeah, some place at basic laboratory result that they can use with the astrop and some machine. But in other community, we don't have anything. The only things I have in the beta HCG for pregnant lady.
Wow, that is austere. Francois, you contacted the college earlier this last year because someone nicked your field guide, and that's why you popped up on my radar. So can you tell us what happened?
Yeah, it's funny story. I was in Vietnam, and because I did a big trip a few months ago, like 6 months, Thailand to Oman by passing by Nepal and a few other countries. And when I passed the security, because I don't have any check-in bag, so I always fly very light, like less than 7 kilos. And when they put my backpack under the machine, they saw the plastic slash metallic gear who hold the guide together. So they see that on the scan, and they open my bag, and the guy look at my guide, and he start to read, and he look at me and ask me if I'm a physician. I said, no, I'm not a physician. I'm a nurse. I say, do you go working? I said, no, it's just I always keep your guide with me when I am on the trip because honestly, a lot of good stuff, lot of good stuff in your Austere clinical skills, the remote life support, environmental medicine. That's the place I always looking when I have some problem. The travel safety, anyway. You know your your good. So I just start having a small chat, and I have to go. I have a plane to take, but the guy just switched pages after pages after pages. And I start folding my things back, close my bag, and I still look at him. And he doesn't want to give me back the guide. And he just fits me. And oh yeah, the important thing is he still have my passport. So he give me back my passport, but he doesn't give me back the guide. So I lost the the Coram field guide at this moment. That's a funny story. I like telling that. Yeah.
It is. I I hope he's using it for some sort of goodness. And he was just a guard. He wasn't medical, was he?
But I don't think so. But you have a lot of small patch on his uniform, and unfortunately, I don't understand Vietnamese, so maybe it's kind of, but I don't know. But I'm happy to if you use the guide or if you know someone who need it.
That's the hope. Yeah.
Yeah, yeah, absolutely.
So you contacted us, and we have sent you a new one, haven't we?
I didn't receive it anymore since since February.
I will follow that up. I will make sure that you
Thank you
get
very
that,
much.
a
And
replacement.
in exchange, I
Yeah.
will make a deal with you. I'm gonna help you to translate the guide in French.
That would be fantastic.
Yeah,
And it would be great to give this guide, French guide, to West Africa and the French if it's written in the Canadian
yeah,
French.
yeah.
That's awesome. Absolutely
And
awesome.
also more for South America, because a lot of people around Suriname and Guyana taught French, and the tropical medicine chapter can be helpful.
Fantastic. Deal.
Deal, perfect.
Absolutely deal.
Absolutely.
So we have a new one coming. So by Christmas, the third edition will be out.
Well,
And from then we will have a chat on French translation. That's easy enough. So I looked through your CV, and you have something called CTAS, the Canadian Triage and Acuity Scale, and I wanted to bring that up. So is that like an early warning? Is that like the News 2 or the Muse scale for Canadians?
um, kind of, but it's more for hospital. The CTAS is more for hospital than Auster. It's 5 categories: severely ill, require emergent care and rapid medical intervention. The number 3 is require urgent care, 4 less urgent, and the 5 non-urgent care. And some hospital create a number 6 out of the book. It's when the patient want a consultation with a specialist without see the ER doctor. So you're gonna be there for a long, long time. But it's more the CTAS is yes, it's more for hospital than Auster.
I see. So you don't use it in the far north.
Yes and no. We use in the hospital. I know in Kuujjuaq, the last time was I was there is around 2019, 2020. They use homemade CTAS, but that worked perfectly. But in the clinic, other place than hospital is a bit crazy, but it's first arrive, first serve. So, but all we always have like we have common sense. If I saw a patient who be very bad, who's doing very very bad, I will take care of him first. but normally it's first arrive, first serve.
That's interesting. So early warning scores is kind of a passion of mine. I'm trying to see what early warning score we can then modify for specific for austere environments. So at the moment, I'm looking at the Muse and the News 2 score, but one acuity scale that I use is called the cell phone or the mobile phone scale. And if the patient is so unwell that they don't care where their phone is, that's very, very, very bad.
Yeah, I will use this one. I will teach my student because I give some clinical assessment course for people right now going back north. I train. I give the training that I received a few years ago, so I will use it if with your. Yeah, that was a good one.
Yeah, so if you're resussing a patient and you're working on them and they get to the point where they ask you where their phone is, you're doing good.
Yeah, yeah, absolutely. The cell phone mobile skill. I love this one.
So, Francois, my final question for you is this. What advice do you have for the new medic, the new nurse, or new doctor who is just starting out in their career in austere medicine?
Don't stop learning. Stay sharp. Because a lot of things can happen in Austere, and it's pretty sure you're not ready for that. We cannot be ready for everything that we receive. So I'll always train for the unpredictable. And the things I do right now, it's I train for the things I don't like advanced burning life support. I I have difficulty with burning, so I train myself in. Oxygen is for me it's nightmare, so I try to do the advanced life and life support in obstetric. In Quebec, we have a course named Gesta for the like the management of delivery baby. So things like that, and also as you know and as you can heard, I'm not an English speaker first. I'm French. I'm Canadian French nurse. I try to be more efficient in English, but also learn the language that where you're deployed. That's helped you a lot. In Montreal, for my English, I use a small enterprise, Ellipse, to help me that. But up north, we use a lot of translation device. We use the translator at the clinic and try to learn the basic of the language. That's make a big difference for gaining the respect of the patient, but also to understand few things that a translation cannot translate. That was my 2 cents on advice.
That's good advice. I appreciate that. Francois, thanks for being a guest on our podcast, and I look forward to seeing what you can do with the French translation of our third edition field guide.
Deal. Perfect. Thank you very much for having me on your show.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.